Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello, everybody, and welcome to another Dr. Journal Club podcast. This is our 17th attempt to record this podcast today. Well, not today, but over like 2 weeks. So we're really hoping that this works out. But we would be amiss if we didn't first talk about the fact that Adam has recently moved across the country. We're not going to disclose his exact location for the privacy of those involved. But tell us a little bit about your new, environment and settling in and all that.
Yeah, so I moved from Portland, Oregon, all the way to the East Coast now for an amazing job opportunity that came up that I could not turn down, and everything with that has been going great. It's still a clinical role. I'm very, very happy and very proud to be where I'm at, and hopefully can provide great care to the community. But yeah, man, traveling across the country solo dolo was pretty crazy. And so part of what I did was a half marathon, basically at each stop that I did. And for those who don't know, Josh and I are doing a lot of triathlon training and wanting to compete in triathlon. And so I was just like, all right, well, I don't want to, I was in a really good groove with my training and didn't really want to give things up, and was also eating a ton of food while I was visiting each city, and so it was kind of my excuse to
run it off.
to run it off, yeah. And so I didn't actually do it in every single city. Denver, Colorado, I didn't do it in because of some time. Needed to make time to get to the next stop. And Chicago, I didn't run because I needed. I didn't need to, but I was hanging with my cousin and didn't want to, wake him up at the crack of dawn. To just let him know that I was going to go run a half marathon in the middle of the dark in a city that I've never been to.
Does he know you're crazy? Like maybe he's just like, oh yeah, I'm not surprised.
I think we're both crazy. So
okay.
Yeah, I think the genes are there, but yeah, I mean, I only spent like maybe a day and a half tops in each city I was at, and so nothing really, I guess, opened until like 8, and I was like, well, I got to leave by like 10, 11 if I want to make it to the next city before it being, like 10 o'clock at night. Mm-hmm. And so, we just kind of get up at the crack of dawn. Well, not really crack of dawn, but like, 5, 6. And then I would go run the entire city and kind of, get my sightseeing in that way, and then go grab some food and go to the next city. And yeah, it was fun. And
that's so cool. That's a big accomplishment.
For the most part, yeah, the weather held up, but in Kansas City, it rained a ton. Mm-hmm. But I had to run a half marathon because I ate so much barbecue that to leave without running would have not been okay.
Yeah. I think that's so cool. You need some sort of medal just for like running across America. And then, but it just hit me because so you were running 13 miles and then you'd get in a car and sit for hours. So did you just come out like a folded human? Like, could you stand up straight when you got out of the car at the end of the day?
Yeah, so I mean, well, also here's the thing too. So like, I kind of planned this trip, but not really. I was just like, okay, everything fits in my car for the most part. It barely, everything just barely fit. And I didn't bring any furniture with me. Like, it was literally just it was 3 storage containers that I just chucked in the back, and my TV, and then some kitchen stuff. Yeah. So did that. And then, I was like, okay, well, my work starts on this date, so I just got to get to where I'm living just a couple days beforehand, so this way I could kind of settle in, and
Mm,
then I should be good. And that's basically what happened. And so each day I was like, how much time do I have? And then just kind of went from there.
nice.
And yeah, got to my apartment, and then remember I don't have any furniture, so first couple of nights are a bit rough.
To the
Had
mattresses. Yeah.
no mattresses. It was
Not
just
even mattresses.
not even a
What are you
mattress.
sleeping
Just
on? You have a
so now I
sleeping
have
bag
a
or something?
mattress.
Uh-huh.
Just
Fancy.
the floor. Just the floor. I was like, there's no point in buying a sleeping bag because I'm going to be getting a bed soon. So why bother? So yeah, just the floor. You know. But
Nice. Very
now I've got
Spartan.
just about but now I've got just about all of my furniture, and I'm settled, and yeah, got my new home, and so did another
Sweet.
10 miles today, so everything's going good.
That's awesome. So, if you're on the East Coast and you see a maniac running by, it might be Adam. You never know.
Yeah.
So, let's jump in and do a little bit of research stuff. We had another request from a listener. This is her, I think, her second request. Thank you for that. So, please, if you're listening and you've got a research study, you've got a question about or something like that, you just let us know. Yeah,
And also,
go ahead.
sorry for the delay in the podcast. We were not ignoring these
Hmm.
requests. It was just that I was traveling across the country, which made podcasting a lot harder. And then also different time zones, and life is just crazy right
Yeah.
now. And so we literally tried to record this specific podcast probably
Yeah,
six
I wasn't
times.
joking about that. It's
And I
crazy.
think yeah, no, we're not kidding. Like, and I think like maybe on a handful of occasions it was like, yeah, we could do it, and then me suddenly being like, hey, I don't think that this is going to be
Hmm.
possible tonight. And then we did, what was it, yesterday, tried to
Yeah, and then
record, and
my internet died just totally randomly. Something about the programming and the money.
so Josh actually uses
That
AOL,
is
the little
slander.
the little CD that the little CD
Slander.
that comes through the mail, and mid recording he actually had to ask his kid to get off the phone because all we heard was the dial-up tone.
Do you remember that? We'd have to fight in our house to like have access to the phone so that we go on little like chat rooms and stuff. Oh man.
It's like, get off the phone, I'm trying to talk to someone.
Yeah. Yeah, or you'd pick it up and you'd hear that dial tone, and oh man, the olden days. All right, but let's do this because something's going to happen, and we're not going to be able to finish this thing if we don't quickly do it. Okay, so the question that we got was, what the heck is the deal with statins? Because sometimes I hear they're awesome. Uh, uh, Folks have suggested that Adam has told them that it should be in the water system, for example. Other times they read something and like it doesn't work at all. So what's the dealio? And we have a bunch of Dr. Journal Club videos that I did years ago on like the Cochrane reviews on this, but they hadn't been updated. And so we thought it'd be a cool opportunity to kind of look at any new studies. And there was a new study and an editorial in like within the Cochrane community, I think just last year. And so that's what we want to talk about today and sort of have that conversation. So I think the study itself is pretty straightforward, but are there some important discussion points that I think will explain whether it should be in the water or not? So how do you want to run this? Adam, do you want to like quickly walk through the study design itself and then we can kind of jump into the meat of
Yeah,
it?
so basically, this was just another systematic review and meta analysis where basically they're trying to update the efficacy of statins for primary and secondary prevention of major adverse cardiovascular events. And the cholesterol treatment collaboration, I think that's the organization, the excuse me, cholesterol, yeah, treatment trialists collaboration did they're a very large organization, and um, they did a very large independent uh, person data meta-analysis where they had data on every single individual, which is very robust data. However, the issue is it's not very replicable if you don't have access to that data. And so this was just a typical meta-analysis where they had only the trial specific data. And really what they were trying to do was see what are the effects of statin on prevention of major adverse cardiovascular events, and reporting both the relative risk reduction and absolute risk reduction, which a lot of the trials don't do. They typically only report the relative risk reduction. And the cholesterol treatment trialist collaboration also only reported the relative risk reduction. And so it's thought that if we can reduce LDL more, then we would get more reduction in risk in major adverse cardiovascular events. And really, from a risk standpoint, there is truth in that. And what they've shown is that for about every 40 milligrams of deciliter per deciliter of LDL that is reduced, we can reduce the risk for some sort of major adverse cardiovascular event by 20% or so on a relative basis, and a 10% reduction in all-cause mortality, again on a relative basis. However, what this study group is saying is, well, although that's great, that might be a little bit misleading, because they're only reporting the relative risk reduction and not so much the absolute risk. And also, there's issues with how we're reporting major adverse cardiovascular events, because oftentimes they're what we call a composite outcome, meaning that if we were to actually see if a treatment were to reduce the risk of, say, of a heart attack, in trials, the chance of a heart attack actually occurring is quite rare. And so you would need either a lot of events to occur, you would need a very, very large patient or participant population, and you would also need a trial that is very long in duration. And that's going to cost a ton of money. And so, some sort of a workaround, if you will, is saying, okay, well, big events would be like a heart attack, a stroke, a heart failure exacerbation, a revascularization procedure, et cetera, et cetera. And if we all count that as just sort of one outcome and label it a major adverse cardiovascular event, and make it this composite event, then perhaps we can get a better sense of the data and not have to rely on more participants, longer duration, very expensive trials to kind of prove the point that we're trying to look at. And part of that issue is that the composite outcome across the spectrum is not necessarily agreed upon. And so you may have one trial group say, okay, our outcome is going to be major adverse cardiovascular events, but that ends up being defined as heart attacks and strokes only. Another group might say, okay, well, we're only going to look at fatal heart attacks and strokes, meaning heart attacks and strokes that result in death. You might have another group that says, well, we're also going to look at non-fatal heart attacks, strokes, and revascularization process, and they're all labeled sort of the same thing. And so it kind of makes the data a little bit challenging. All that to say is what this group tried to do is look at the data again and look at it from both a primary prevention standpoint and a secondary prevention standpoint, and see how or see what the magnitude of effect of statins are on preventing the outcomes of heart attack and stroke within the primary prevention and secondary prevention group, and how that's related to the LDL reduction.
Yeah, no, I think that's great, and I think like let's briefly talk about those results, because I think the obvious story here is what they're trying to do is talk about the difference between talking about these effects as relative or talking about these effects as absolute. So let's briefly talk about like what that could look like. So they had 21 different studies. And what they found for all cause mortality was a 0.8. Yeah,
Well,
go ahead.
before we get into that, do we want to kind of review the difference between relative and
Yeah,
absolute?
let's go through the results first and then explain why they look so different.
Sure.
Just because I think
Yeah.
if we have real numbers, we got stuck on this on like the fourth time we tried to do this this recording. I think we got stuck in the numbers. So this is what they found. So if you look at all cause mortality, if you take statins on an absolute risk reduction level, you've got a reduction of 0.8%. So not very large, but on a relative level, that is a let's see. Um, where's the?
The largest reduction was in 38%
Oh, they just report that. Okay.
from a relative standpoint, but that only resulted, I think, in like a 0.8% absolute
Yeah,
standpoint.
sorry about that. Okay, so let's look at this again. So let's look at the what would be the most impressive first. So that's gonna be secondary prevention. So these people like have heart disease already. Maybe they already had a heart attack. So these people are most at risk, right? So we would expect the largest effect sizes. So if we look at a relative risk reduction for all cause death, we've got a 14% reduction. Okay, so kind of sounds pretty decent for something so important. But if you look at it from an absolute risk reduction perspective, it's just a 0.9% change, right? So it sounds a lot lower. MIs, 27% relative risk reduction, right? Sounds really high, but that's just a 2.2% absolute risk reduction, right? And we're going to talk about what these differences are. But this is the main point, I think, on a meta level is like, if you're just talking about the relative changes, it's always going to look better. And when you have people talking about and having informed conversations with patients about statins, that is often what's presented. And I think the point of the authors is if you're thinking about it on absolute levels, those numbers are actually much lower. And that's when, so for our dear listener, like that's probably what she's seeing. Some people are, it's the same data. Some people are focusing on the relative reduction and some people are focusing on the absolute reduction. So let's talk about what the heck that difference is, because I think that's the crux of it here. Cool.
Yeah, and I think the best way to think about that is if you were to see a commercial or you see an ad that a store has a 25% sale, and the item that you're trying to buy is $10. Applying 25% to that, you're just going to go from $10 to $8. So, on a relative standpoint, there's a 25% reduction in the price, but from an absolute standpoint, it's only off by $2. And so it would not be
But
very.
if you bought a TV, but if you bought like some massive TV for $4,000, that 25%, now we're talking about real money.
Yeah,
And that's the difference, right?
yeah,
That baseline risk, aka the baseline cost of what you're buying.
exactly. And so, if you're a store, you're more enticed to say, hey, the store is 25% off, as opposed to saying, hey, everything's $2 off,
Mm-hmm.
because 25% sounds bigger, it sounds sexier, more people are going to be attracted to that, they think they're getting a really good deal. And
Yep.
so if you're a pharmaceutical company or you're some sort of industry, or if you're a supplement company, it doesn't really matter what company you are, if there's any sort of industry sponsorship involved, you're more likely going to want to report the bigger or sexier sounding number. And part of the quote unquote issue with these trials is that they are largely funded or influenced by a lot of the pharmaceutical industry. And so almost all of them report on the relative risk and kind of leave out the absolute risk. And it's not necessarily a bad thing to do, and they're not wrong for doing it. It's just that if you don't have that context or that ability to know how to convert a relative risk reduction to an absolute standpoint, then it can be misleading. And unfortunately, a lot of people don't have a good sense of statistics, so they're not really knowing what to do with that information. And
Mm-hmm.
so, if you have a patient in front of you and all you have is the relative risk reduction, you can still find out what their baseline risk and how much benefit they're going to get, specifically from a cardiovascular standpoint. If you use the American College of Cardiology, um, you know, the ACC-AHA cardiovascular risk calculator is what it's called. You can determine a patient's baseline risk using specific data that takes into account like their age, their sex, their hypertension, their blood pressure status, their cholesterol panel, are they a smoker or not, et cetera, et cetera, et cetera. And then you can kind of go from there. And so if the patient in front of you has a baseline risk that you're able to calculate of 10%, and you have a trial that says, oh, with this intervention, you can get there's a 25% risk reduction. Well, you can still figure out that absolute risk by applying that 25% to that baseline risk of 10%. And it's going to go down from 10 to 8%. So it's kind of the same thing. It's just not directly being reported. And so you just kind of have to do a little bit of work on your own to figure that out.
Yeah, and so that's perfect. And so let's play with that example a little bit further. So let's say your baseline risk of having a heart attack in the next year is 10%, right? So that means of 100 people with this risk, 90 of them are not going to have a heart attack and 10 of them are, right? That's one gross way to think about it. And if you reduce that risk by 20%, now instead of 10 people having a heart attack, only 8 people are going to have a heart attack, right? So what have you changed really? Just 2 people, 2 out of 100 people difference, right? Everyone else was either going to have a heart attack anyway or not going to have a heart attack anyway. And the way thinking about it in this way, the number of people you need to treat to prevent one case of something, we sometimes call that numbers needed to treat. And conversely, all the people that are treated where they don't benefit, we sometimes call that numbers treated needlessly for the same idea, was that they're not going to have a heart attack anyway. But if you have a high risk population, let's say 50% risk, and half of these people are going to have a heart attack anyway, and you drop that by 20%, these are real numbers. So I think the real
Hmm.
take home is it's all about a few things. One is the baseline risk, right? In which case it is going to be more impressive. But in a primary prevention environment where your baseline risk is really low, the question that the authors are saying is not that you shouldn't use statins, but just be aware that the marginal benefit is less impressive than it may sound if you just say, oh, there's a 25% reduction type of thing, right? So I think
Yeah.
that's the main takeaway. And the other thing, so talking about it in absolute versus relative terms, I think is part of the debate. But the other thing is this composite thing, and I want to get into that a little bit because I used to feel like composites were evil because that's what evidence-based medicine folks said, because it's people define it differently. And sometimes people say, well, if you have chest pain, even if it's not a heart attack or anything, we'll include that in the composite. And now you're basically juicing your numbers, essentially, is what it is, because you're basically putting everything in one bucket and your things are looking more impressive than they would otherwise. And so there's some point to that. But on the flip side, if what you care as a clinician about is not just I don't want to have a heart attack, but I also don't want to have a stroke, and I also don't want to have a procedure or a stent, right? So these are all important outcomes. It kind of does make sense to bulk them together. And the more I thought about it, the more inappropriate it seemed to piece them out, because that's what the authors did here too. Instead of looking at composites, they just looked at MI or they just looked at stroke. And when you just look at these individual outcomes on an absolute level, yeah, they're really really small. But again, a patient's going to care about like all the big outcomes, right? They care perhaps equally if it's a heart attack or stroke, or they're both really important. Death is kind of important too. So I don't know. I think I'm changing my opinion on that. I think composites do make sense. And I think maybe the authors have overcorrected. I want to get your take on this, which is that traditionally everybody made things look too rosy. They used big composites. They reported relative risk. Everything looked amazing. Everyone should be on statins. But I feel like these folks have kind of gone the opposite direction, reporting absolute levels, reporting on individual levels, MI, stroke, when really we would care about all these things. It almost makes it look too low, essentially. And the truth might be somewhere in the middle.
Yeah, no, I agree, and I think that when it comes to composite outcomes, as long as what that's involved in the composite makes sense, then I'm okay with it.
Hmm.
Heart attacks and strokes and heart failure exacerbations. These are very important things that we need to prevent and address and try to be really good at treating. And so those things make sense. But if it's like, and this is just for the sake of making a point, if it's like heart attack, stroke, heart failure exacerbation, ear pain, like why that composite doesn't make sense, right?
Yeah.
And I think going back to the point you made before we started talking about composites, I think that we also have to take into account that these numbers are low, right? From an absolute standpoint, the numbers are not as robust as a relative standpoint, and it's disappointing, especially when as clinicians we want people to get better, and then when we see these really sort of in these low numbers, it kind of becomes a little bit demoralizing. But we also have to take into account, one, what are the other options that are out there?
Mm-hmm.
Two, when we then apply this to a very large population, that the effects get bigger and bigger and bigger, and so then they become more meaningful. And another thing to take into account is you don't know the person that you're treating, which one is going to get the benefit and which one's not.
Mm-hmm.
It's not like if you treat 100 people that you could say, hey, you're the one who's going to get that benefit and the rest of you aren't. Like,
Yeah.
I have no idea.
Mm-hmm.
But what I do know is that if I treat all of you, I'm reducing that risk in all of you, and at least some of you are going to benefit given like everything that we're doing, and there's no other option available. So from a medical standpoint, this is where we're at, this is what we can do, and here's how much benefit you're going to get given your baseline risk. Do you want to proceed with that, yes or no?
Mm-hmm.
It's up to the patient to make that call of, hey, I'm gonna say yes or I'm gonna say no. And it's for us to respect that decision at the end of the day, and just know that as long as the patient is informed fully of the risks and benefits, and sort of all that stuff, well then we've done our part.
Yeah, and I think that's what the authors are really saying is like this just needs to come into the discussion with the patient, because as opposed to assuming, well, you reduce your risk of a heart attack in half, so just do it, right? Actually, it's more nuanced than that, right? They're very unlikely to benefit if it's a low baseline risk, and so just have that conversation. Look, the thing is, we don't do this for money. This is pro bono. And quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence based medicine and integrative medicine is essential. And there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. And another thing that was really, I might have talked about this before, but at the conference in Toronto, the PI conference, Dr. Guyot presented. Did I ever talk about this? The stroke prevention study patient preferences. Does that ring a bell? This blew my mind. So basically, like, I can't remember the exact details, but essentially, there's like, okay, well, if you take warfarin or you take, blood thinners or whatever, you reduce your risk of stroke by a certain percentage, but you increase your risk of having like GI bleeds, right? So that was the trade-off, right? And so they said, okay, well, if we present this information to patients, say, yeah, we reduce your risk of stroke, but there's this potential risk of GI bleeds. And when they looked at the numbers, they're like, well, really only reduces your absolute risk of stroke by like this tiny amount, but you have a pretty decent chance of having a GI bleed, right? So the clinician then in the study, the researchers asked the clinicians like what would be preferred, like what they thought would be preferred, and the clinicians are like, well, if the trade-off was preventing 10 strokes per 100 GI bleeds, they had some estimate, right? And then they asked the same question to patients, and their threshold was totally different. And when you overlay the graphs, it was like two completely different forests there. And essentially, and it totally makes sense to me, if you ask a patient, if you take this drug, you have a pretty decent chance of getting a GI bleed, but you'll reduce your risk of stroke. Now, it's not going to reduce it a lot, but it's going to reduce the risk of stroke. Turns out most people will take that because they're just so terrified of stroke, understandably. And so I think that was really interesting to me, is like, because when he asked, well, what would you vote for? I was using my clinician head and I was like, oh, I don't know, maybe for every stroke, 10 GI bleeds or something. But then on a patient level, it was a totally different calculus. And it just speaks to the need for informed decision making with patients, because even if you assume these benefits are marginal, like I'm kind of making that argument for here, on a patient level, it's like, well, I don't want to die. I don't want to get a stroke. I don't want to get an MI. And yeah, if you're only preventing 7 cases per 1,000, maybe I'm one of those 7, right? And if the trade-off isn't crazy, like, I want to take it. But someone else may have a totally different take on it. So again, I think it comes back to patient decision making. The answer isn't obvious, even when you give people these like absolute numbers.
Yeah, Yeah, no, that's a good point. I mean, I think one thing too where I would not hesitate, but I think one thing that needs to be taken into account is like if you say GI bleed, I think a lot of people freak out, and rightfully so. But like if you were to then further define GI bleed, like okay, how many of these GI bleeds require like an admission and are getting banded versus like, hey, just take some omeprazole and stop your medication and then things resolve. I think is something also that would kind of like need to be teased out. Like how many of these GI bleeds were like life threatening GI bleeds versus just like not as severe, and then kind of rephrase the question of like, hey, okay, if we gave you this medication and we were able to prevent your stroke by this amount, but your risk for a non-life threatening possible intestinal bleed would be this, if that would be viewed differently. But again, I think you still have to respect the patient's decision at the end of the day.
Yeah, absolutely. And again, like that should all go into these informed discussions. And, it comes down to, the stuff Montori's doing with decision aids and having these visuals where you can kind of visualize these trade-offs. 'Cause it's all about trade-offs. And, some people are going to be more worried about side effects than others. And also there's alternatives, right? So like, it's not just this isolated question. It's like, well, what if I did diet and exercise, or what if I took this supplement? And then you have all sorts of other discussions and patient values and stuff like that. So I think that's important. And then two other things. I wanted to circle back to your comment about, yeah, on a population level, though, even these tiny, 7 per 1,000 difference matters. It adds up across 100 million people, a billion people, et cetera. And yeah, so and we've talked about this before. That speaks to like, are we making decisions on a societal level or an individual level? And I think it depends on the audience. And Guyot's argument has always been, that I understand it, is in clinic, it's an individual's perspective. You take the individual perspective. But if you're in public health, right, like you may choose to have big pushes on awareness around statins or change your EMRs to promote statin use, because on a population level, that does make sense. But I guess where I think some clinicians are running into stuff is they're trying to make individual decision making with patients, but the societal pressures are pushing in the opposite, in a different direction, let's say. And I wonder if there's enough comfort and CYA stuff to say, no, we had this discussion, we know what the recommendations are, and this is what we decided to do. And I think, again, that's kind of it's a bigger issue with guidelines and how strict they need to be and how strict you have to follow them. But I think that's part of it as well.
And um, I mean, I think something too is like we can't view these things in black and white in a vacuum of like, I feel like a lot of clinicians are especially within the integrative field are saying like statins are good or statins are bad, and there's no sort of in between or any sort of clinical context that's taken into account. It can be very almost like religious or politicizing, and I think that we really need to refrain from that and just, again, what is the clinical question that is being asked? What is the data that supports or refutes that? And what are the patient preferences? And go from there. So you can't use the study to say, oh, yeah, see, I knew that statins were bad and that they're totally useless. Look at this paltry 1.2% absolute risk reduction. And then on the flip side, you can't, do the opposite either. I think there is a middle ground, and you have to take into account, like I just said, patient preferences, baseline risk, talking about risks and benefits. Are they already doing all of the things? Is there areas for improvements that can maybe delay something, or like, hey, no, like you're at very high risk. This is the best tool that we have right now. And like, really, we should be on this because we want to reduce that risk as much as possible. And I have no idea if you will or will not ever get some sort of event, but this is the one thing that we have that may be of benefit.
Yeah, like if someone doesn't get a heart attack, you don't know if that's because they're on the statin or they weren't gonna get one anyway. And conversely, if they have a heart attack, it's like, well, did the statin not work, or you were gonna have one anyway, type of thing. Or so that we'll never know for sure. And so yeah, I think it always comes. I don't think you can go wrong by just defaulting to the patient and then charting the heck out of it if they're making a decision that you think would be very different than would make sense to you or to guidelines. And then the last thing I'd say is I think they took a couple cheap shots in this paper. Like they had a very clear, like I think they had a very clear premise they wanted to make. And one
Yeah.
of the cheap shots was like against the collaborative that did the individual participant data meta-analysis. They were like, well, that information is not available to us, so it's not reproducible. So we're just going to do our pairwise meta-analysis. And I was like, IPDs, individual patient data meta-analysis, are extremely powerful.
Yeah,
And
I
like there's
am in
yeah.
alignment with you of like,
Mm.
hey, like you can't just say like, oh, we don't have access to the data, therefore like
We can't
that
trust a
is not
really
good.
powerful, amazing result. Yeah, I know.
Yeah,
I was
it's like
like,
okay. Well, when I read that, I was like, this is
that's a
this is
cheap shot. Yeah.
that's a cheap shot. Yeah, it's like you can request the data and then take your time and repeat this, but like
Mm,
you're probably going to get the exact same result because again, it's individual patient level data.
yeah.
What would make you think that you're going to get anything different than what's already entered there from a data
Yeah,
standpoint?
exactly.
And then also like what would that organization's like bias be to lie about any of the data?
Yeah, I didn't track with that at all. And the question they were trying to answer, which they said they didn't have enough power for, was based on how much you reduce LDL, are you really? Because they were also trying to call into question the connection between LDL reduction and these impacts on cardiovascular disease. And they couldn't really say it with the pairwise meta-analysis. And I'm like, well, no kidding. Like you're limited in power. If you have an
Sure.
IPD, you can absolutely answer that question. And so, yeah,
And also, I think too, like you have to take into consideration all forms of the data that's available out there when you're trying to
yeah,
answer that question of like, is LDL causal in cardiovascular disease? And the overwhelming data does support that being the
yeah,
case. When you're looking at observational data, randomized controlled trials, Mendelian randomization controlled trials of both people who have genetic predisposition to overproduce LDL as we see, or can't metabolize LDL well as we see in people who have like familial hypercholesterolemia. These are people who are having heart attacks like in their early 20s and then when they're on statins are actually able to live longer because you're reducing the LDL because it's not so high. And then when you're actually looking at Mendelian randomization studies of people who have a genetic predisposition to have very low levels of LDL, we're seeing that they're actually living longer. And then that's actually how PCSK9 inhibitors came onto market, is because we were looking at the PCSK9, essentially the PCSK9, I think it was the gene in there from the Mendelian randomization studies, but don't quote me on that. And so, from a causality standpoint, we do know that LDL is very heavily involved in that. And so, again, when it comes down to risk management, if we can lower something that is so influentially causal in these events, then why would we not try to, at least offer it?
yeah. I think so. And I think that the take home of the paper is like absolute effects are going to be smaller than relative effects. And I was like, well, okay, no duh.
Oh, and they always will be. They always will be.
Yeah, they always will be. Like by definition, they always will be. And so, I mean, insofar as they're saying it's misleading that these important trials don't also present absolute data, I agree. But also, I don't think it's that much of a oh my goodness that absolute effects are going to be lower than relative effects. But to their other take home was like, well, you should share that with the patient. Yeah, I also think no duh. That's a good one. And if this brings attention to that, absolutely. And I think the other thing we should do, I was going to propose, is next week we actually read the meta-analysis that the collaborative did,
Mm,
that this group is kind of contrasting with. I
sure.
think that would be interesting as well. That'd be kind of a neat sort of alternate view. But yeah, I think that's all I got on this one. It was a cute little study trying to show the importance of looking at absolute effects. I thought that was fair. Take home is talk to your patients, share all the information, let them decide. Yeah, and should we leave it there? Anything else you want to add?
Well, I do actually want to add one thing is, and this could actually open up a can of worms, is like if we're going to report both relative risk reduction and absolute risk when it comes to these kind of things, what are we going to do then when it comes to like smoking cessation,
Mm-hmm.
where you want the relative risk reduction to be a larger number and to like get people to stop smoking, you would want to say, hey, this has a 30%. This can reduce your cravings and whatnot by 30% and increase your success for stopping smoking. But then if you report the absolute risk, and I don't know what the absolute risk is for all the smoking cessation agents, but let's just say for the sake of argument, let's say it's only 2%. You were to say that to someone who's trying to stop smoking, perhaps they're going to be like, well, then why bother?
Yeah. So it goes back to your
So now we have a moral dilemma.
well, it goes back to your motivation. It's like if your job is to reduce death in society,
Harm,
yeah.
or deaths, then yeah, I think then yeah, then that you make a good point there. But I just think it was something that's interesting.
Well, no. So let's double down on that a sec. 'Cause we got a little bit of time because I think this goes back to like some of our early conversations about vaccines, and I'm like so interested in this because
And that's actually really important. That's really
Mhm.
important. Of the relative risk reduction when it comes to vaccine research is actually the preferred number to report over the absolute risk, and there's a number of reasons for that. But it is correct to report the relative risk reduction when it comes to vaccines.
Oh yes. Oh, that's a good point. So don't think that they're trying to pull the wool over your eyes because baseline risk varies so much over the seasons. That's right. The relative risk is the better thing, and then you apply baseline risk. But
The reason being for that is because oftentimes when it comes to the relative risk, it's essentially, you can view it as like a standardized number of like, okay, across the population, everyone will get this relative effect, but then their baseline is going to be different,
hmm
and so that's why that it's important
yeah,
from a vaccine standpoint.
yeah. I remember we had this conversation. I can't remember which episode number, but we looked at a bunch of the COVID vaccine studies during the bad years, and one of the they had these huge, very impressive relative risks, and then you looked at the absolute numbers; they were like paltry. But it was because the studies were done at the very beginning of COVID, and so your baseline rates were very, very low. But of course, when the study came out and we had to look at the answers, the baseline risks were huge. Like everyone was getting it, and so it would have been inappropriate to focus on the absolute numbers there and as opposed to the relative, just like you're saying. So totally agree. But I want to circle back just super quickly to the philosophy of this. Like, what is the role of the clinician? Are we meant to help society? Are we meant to be sort of like pocket public health advocates? Are we meant to just be advocates for the patient and helping them make their own informed decision? Because they don't always align. And I don't know. I think a lot about that. I mean, what do you think?
I think yes, in the sense, or to the public health comment, I do think that we need to, um, promote public health. I think, because public health does influence individual health, and individual health affects public health, and so I do think that as clinicians, it's important to do both. They're not separate entities; they both affect each other. Um, and sorry, I got distracted. I just got actually a presentation accepted for the International Congress of Integrative Medicine. So I was reading
Oh, congrats.
thank you.
Nice.
Sorry. So repeat your question.
Oh no, just big philosophical questions about what's our role in society and the world.
No, but it's important. Ask again. Ask again.
Well, I guess, and it's not a dichotomy, but I often struggle, maybe because of the population that, integrative docs tend to work with, like the public health mantras, public health cannot have nuance. Like this is what I'm settling in on. Public health cannot have
I
nuance.
think the message of public health
Cannot have nuance.
cannot have nuance.
Yeah.
And the reason being is because you have to be able to also talk to people who are not as who don't have as great health
hmm
literacy, or don't understand certain things that are happening. It's not that they don't understand it, but the message that's being sent out
hmm
may not be well understood, and so we have to make it to the like lowest common denominator so that everyone can understand it.
Yeah.
And so and so that's why we try to keep it as simple as possible, as
Right.
large of
Don't smoke. Period.
yeah,
Right.
don't smoke. That's it.
Right. Yeah.
I mean, there's really no nuance in that. Like, don't smoke. If for other things where there is nuance, we have to try to be able to capture the largest population that we can. And then from there, the clinician should really talk about the individualization of that, But for a lot of health things, we have to make sure that everyone is being able to receive, or at least know about the risk, or see what treatment is out there. So,
Yeah,
yeah.
I agree. I mean, I think I get rankled. What's the word? Rankled? I don't know. I get
Riled
I
up.
get riled. Well, I don't know about riled up, but like my hair gets up like when people make these blanket statements about anything. Because just like as a scientist, as a doctor, it's like nothing's that simple, right? Like it's kind of absurd that you would say that. But I get like behaviorally, like if you're messaging and your outcome that you're looking for is the maximum number of people vaccinated, the least amount of MIs, like then yes, simple messaging and convincing. And maybe I just can't. I would be a terrible public health servant. But on like a individual level, like things are nuanced, and yeah, that's exactly when you have those conversations. I think what what can sometimes be an issue is when the public health argument is so strong, and then you're having these conversations on an individual level. Like, how does that influence those discussions? How does that influence how you feel about yourself? Um, yeah, I don't know. It's just I don't know if I'm making any sense, but I think it really depends on the worldview that you're taking, and I think primarily doctors are should take the individual perspective with their patient in their room. But if they're making public statements on Twitter, like they should probably take a public health perspective.
And yeah, I think that goes back to what I was saying earlier, is that they both matter. Public health influences individual health, and individual health affects public health, right? If
Mm-hmm.
if you're somewhere where there's no public health, and you don't have good drinking water, and you don't have access to stuff for preventing sexually transmitted infections, and you're in a food desert, and you have these things where we take for granted, because the public health, for the most part, really is really good in this country relative to other countries where perhaps they don't have a strong enough public health component or infrastructure. And so we end up taking that for granted, and it allows us to then focus on the individual. Whereas if we had a really bad public health system, well, then we wouldn't really be able to kind of have the privilege of talking about these individual issues.
Yeah, I think that's right. And in a microcosm, I think that's what the vaccine issues are, is that when you have really good public health and very few people have the baseline disease, the benefit on an individual level shifts. And so now people on an individual level are saying, well, I don't need a vaccinate. Like, who has this disease anymore, right? But enough people make that decision, and now you screw all of society because you get past the threshold.
Right.
And so, to your point, is like as public health improves, the calculus shifts on an individual level.
Mm-hmm.
But then if that affects change, the public health situation is going to change too. So yeah, it's just it's an interesting. It's not a conundrum. It's just an interesting phenomenon, I think.
Yeah. And I mean, I think that and we can get into like a real deep rabbit hole here of like, how far can society go before we start complaining about like things that were never on the radar, just because there were so much like bigger things to worry about. We don't have to worry about polio being endemic in this country, so it allows us to focus on this other health thing. But if polio were to suddenly become endemic again, well, then we would be focusing on that and not that other thing that we were worried about earlier.
Yep, totally. Should we leave it there?
We should. Yeah.
Okay. Awesome. To be continued. Thank you again for the topic suggestion. It's always fun to talk about absolute relative risks and to sneak some philosophy in at the end. Yeah, I agree. Apologies for taking us a while to respond to specific listener requests. I think we still have one paper left from Dr. Garovich that we need to talk about. I want to do this collaborative trialist IPD meta-analysis. And then, yeah, if any listeners have more studies they want to ask or big questions, big topics they want us to cover, just send us an email at josh@drjournalclub.com, drjournalclub.com. And yeah, we'd love to go through it.
Awesome. Take care. Thanks for listening.
Okay. Take care, everybody. And congrats on your new home, man. That's
Awesome.
great. Bye-bye. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, DR Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.